Thank you very much, and good morning. Actually, I'm so happy, this is my second time to come to this conference room. 20 years ago, actually, I came here, and for, I think, a kind of, the government exchange kind of between the health professionals, actually, between the United States and China. And last time, actually, I end of my topic is that I hope that the indication for the drug, for a new drug, is like that. The indication for some specific disease with some symptoms from Chinese medicine and without of some other symptoms in Chinese medicine. So that means we try to clarify the indication more precisely. I think that's bridge between Chinese medicine and Western medicine. So I need to introduce the School of Chinese Medicine with a couple of minutes, and it's in terms of research, actually. So even the School of Chinese Medicine in Hong Kong, our school is the biggest one, but it's still, I should say, it's a focused, smaller one. So we are focused on some, niche area. We just focus on not whole area about medical science. We are focused on the standardization of Chinese medicine, also for the integration of Chinese medicine with biomedical sciences. So the major research area include the phenomic study. That means try to integrate the Chinese medicine phenotype with gene or protein profile, actually, in terms of Western medicine. And also translational medicine and innovative drug discovery. So we try to use Chinese medicine-inspired new drug discovery based on Chinese medicine, herbal medicine compound, and biomedical sciences. And also we are doing that authentication and those, what's the high quality about herbal medicines. Sorry. So we have theme-based research centers in the School of Chinese Medicine. So we focus on the cancer, inflammation, bone and joint disease, and Parkinson's disease research, and also the Chinese medicine clinical trial study. So that's for design and for the clinical trial about Chinese medicine based on the Chinese medicine theory. And also we have the renal disease research center and also the standardization of Chinese medicine. And like Tim mentioned that, we have Institute of Integrated Bioinformedicine and Translational Sciences. So there's more combined system biology and bioinformatics with Chinese medicine. Last academic year, actually, the school obtained 21 external grants, and including NSFC, that's from mainland, and Hong Kong collaboration project, and also for GIF, this Hong Kong major basic research supporting scheme. And ITF is for more like for a translational study, and also from Health and Medical Research Fund. Last year, we published about 130 refereed papers, and about 30 papers actually published in impact factors at 5 or above, including Science, Nature Communication, Nature Medicine. I think these representatives actually for the publication in the School of Chinese Medicine, and we hope that we can explore more collaboration worldwide and try to enhance the research, especially in terms of Chinese medicine. This kind of example of current major project, just last month, I think, or last 2 months, I forgot that. So we have cell line actually in the Tianzhou as for the bone loss. Actually, we use our cell lines, put into the Tianzhou as for test the gene, how the gene will be impact on the bone loss for the astronaut. And hopefully we can try to, screening those natural products from herbal formula and try to find out those, whether food supplement or even new drug for the bone loss, actually. And also Chinese medicine digital project and the big data project, we are ongoing that. We try to integrate Chinese medicine data, those major in Chinese and also from, gene data, Medline data, those biomedical data in the English. So we try to build up Chinese and English interpretation standards. Actually, we are doing that and hope that this kind of big data project can enhance both biomedical science research and also the Chinese medicine research. In the school, we have about 40 PhD students, including some of them is small part of the MPhil student. I think that's basic introduction about the School of Chinese Medicine. So I tried to, change my channel to the my topic, how to do that. Okay. I need my glasses. Okay. Yeah, got it. Okay. So my topic actually is continue to the topic, 20 years ago. So how to change the indication of a new drug. That means how can we use the drug more precisely, whether it's Western drug or Chinese medicines. Because once become a therapeutics, actually we don't care about the Chinese medicine or Western medicine. We just cure the patient, right? So in the medical science, I should say that two important factors. One is classification, or we call diagnosis. Another one is intervention or therapeutics. That should be based on the classification. So my topic today is to try to clarify or build a bridge between disease diagnosis in medical science, in Western medicine, and pattern classification, or they call it Zheng, or syndrome differentiation. I like to call pattern classification is a more easy way. And in Chinese medicine, how can be combined and what's the future? I think that to see a doctor, actually, if we come to a clinic, the Western doctor, they try to diagnose the patient. So they have exactly clinical practice guideline. What's the diagnosis criteria? Let's say rheumatoid arthritis. So we have ACR and the 7 standards, actually. Okay, once you get either 6 or 5 meets the criteria, and so the diagnosis for rheumatoid arthritis is defined, finalized. That's fine. And then you just follow that clinical practice guideline and use the drug or drug combination, whatever. So that's Western medicine. And once the patient comes to see a Chinese medicine doctors, once even finalize the diagnosis as rheumatoid arthritis, the doctor will ask the patient, what's your feeling? Are your joint pain? You feel cold or feel hot? Your pain is like warming up or like cooling down. Even the symptom is going to be different. I mean, the Western medicine don't care about anything about this kind of symptom, but the Chinese medicine care about this because a different symptom means different subgroup of that patient, even same disease. So I think that's a big difference. So the classification is a big difference. So of course we know that holistic, other type of concept is completely different. But I think that even to build a bridge, I think we have to choose the closed one. We cannot overlap whole Chinese medicine and Western medicine. So we try to build up the classification first. We can classify the patient with specific disease into the different Chinese subgroup or patterns. If we can do that, and then you can improve the efficacy for a specific therapeutics. So this is the way for the Western medicine. So we have 10 patients get some disease, same disease, let's say rheumatoid arthritis, and then clinical practice guidelines tell us that, okay, the first choice or priority choice that option 1, and they use option 1, and the effect rate is about 40%. Okay, fine, 4 out of 10 recovered. And how about another 6th one, and then you can choose option 2, and then 50%, and then you can continue to change your options, even combination. I think that's the way for the Western medicine, because the clinical practice guidelines tell us that. That's the way we do that. And then follow that with medical assurance coverage. Otherwise, no medical assurance. And what's Chinese medicine? okay? Even 10 of the rheumatoid arthritis, the patient. The Chinese medicine doctor will try to classify those patients into different subgroups based on the feelings, the symptoms, the Chinese medicine symptoms, like, they like a feel cold, feel hot, like a warming up, whatever, okay? And how they classify the patient, they like use, looking, smelling, or feeling. So it's more like I always say that engine program say, if we experience engineer, they just listen to the sound, okay? And then they know that it may be tube problem or electricity problem. Actually, it's based on the experience, try to classify the patient into different subgroups, and then use complete different therapeutics or interventions. I think that's different. So the difference is that Chinese medicine try to classify the patient more specifically, actually, or try to classify the patient to different subgroups, and then use the intervention accordingly. So what we did, actually, let's say, the Chinese medicine pattern, is that relation or related to the efficacy? I can tell the clinical trial, the result. Okay, let's say that. We can see here, we still, rheumatoid arthritis, the common therapeutics, we use MTX and SSZ, this combination, that's generally recommended for the treatment in the RA, in the rheumatoid arthritis. But actually, when we conclude the clinical trial result, we can see here the cold pattern RA patient. And undefined, that means not hot pattern of that RA patient. They feel much higher efficacy, effective rate. That means MTX treatment is much more useful in the RA patient with Chinese medicine cold pattern. So that would be better, actually, because the Chinese medicine can help, doctor, whether Chinese medicine doctor or Western medicine doctor, to classify the patient into more specific or well-defined for that intervention subgroup. So another question is that any scientific proof for that? That means you're feeling cold or feeling hot, like warming up or cooling down. Is any biomedical evidence to prove that? So we tried to find out typical RA patient with Chinese medicine cold and hot pattern. That means two different subgroups. And then we use bioinformatics or genotype, metabonomics, those omics technique. We try to classify the two subgroup of RA patient. And we can see here the cold pattern and hot pattern. They're completely different. Even those 7 clusters of pathways, they're not closely related to the immunology. But they too related to those different situations of that patient. Of course, the central one, cell cycle immunology, that's directly related to the immunology or directly related to the rheumatoid arthritis or autoimmune response. So, and then even the patient actually, even the RA, same RA, they can be different way, can be the hot pattern, can be the cold pattern. So that means at least RA patient can classify into the 2 subgroups, A or B or cold or hot or whatever. So of course, this is more like, metabolite, pathway about the cold and hot RA patient that different. So we can show here, cold is more like aspartate metabolism, and hot is probably in different, metabolic way. It's completely different in the 2 subgroups of that RA patient. And also we try to find out some biomarker. It's more difficult actually, because it's one biomarker, one protein or one gene it's real difficult to classify cold and hot pattern of our patient. But at least we find that one of them is a CRP, C-reactive protein, is more related to the hot pattern of that patient. That patient is not good for the MTX or SSZ or Western medicine treatment. And my colleague, Professor Zhang will talk about that later, about the combination, how to find out natural product to combine with nowadays Western drug to improve their efficacy for that eye patient in the hot pattern of Chinese medicine. Yeah, this is another diagram to show that hot and cold pattern is different. And also, we try to find out, we know that we can find out different pathway in the hot and cold pattern of eye patient. But another important that we show that the hot and cold pattern can be treated by different therapeutics. That we know that already. We can use bioinformatics. We know that herbal formula, network pharmacology also include MTX and SSZ. They are we can use system pharmacology approach, and then we can overlap those. But exactly that, we can see here, herbal formula is much more easy for the eye patient in the hot pattern. And in this side, we can see here, MTX plus SSZ is more suitable for eye patient in Chinese cold pattern. So in terms of system biology, we can show that evidence. So the different intervention can be different efficacy for different pattern of the eye patient in Chinese medicine. And in Chinese medicine, actually, because the feeling can be changed somehow, especially like eye patient for the intervention period of time, at least need 6 months. So the feeling can be changed. That means the Chinese medicine say that the pattern may be changed. And the pattern change usually need to change your therapeutics or change the intervention. But in the real clinical trial, it's hard to change the intervention because it's well designed already. And of course, we try to figure out who will be changed in terms of Chinese medicine pattern. So we actually, in our clinical trial, the 2 clinical trials actually, it's about 10 or 15% of those patients among 300 patients. The Chinese medicine pattern would be changed. That means from a cold pattern become non-cold pattern. So they can change somehow. So we can explore the change, so we can find out the change pathway. Because you know that the middle of the cluster, they are all related to autoimmune disease for the rheumatoid arthritis, and the other 2 parts, actually, the connection, once a change somehow, so the pattern in Chinese medicine may be changed. So the change we can follow in next clinical trial. So we need to follow those, even small part of the patient. We need to follow those patients into different stage, and we try to select another one or another intervention for that patient. So, and then what we should do for improve the efficacy? What we did, we need to change our therapeutics. We need to improve the efficacy for the patient. The patient, they don't care about anything about Chinese medicine, Western medicine, Chinese drug or Western drug. They need efficacy. They don't care about anything. So the basic research, including classification and intervention, we need to improve the efficacy. So my idea is that we need to at least 2-round clinical trial, and then you can improve the efficacy. So the first one is that open clinical trial. Let's say one intervention. Let's say MTX plus SSZ, the general treatment for the rheumatoid arthritis. And then we recruit 100 patients, eye patient, well diagnosed, okay, well diagnosed in Western medicine. We don't know the Chinese medicine pattern because we don't know the pattern related to the MTX and SSZ treatment. So we don't know that exactly. So in the open recruitment for that, we can see here that basically the ACR20, that the effective rate kind of indicator actually, is pretty same, about 60% worldwide. So that means general intervention for the eye patient, the effective rate is about 60 or 65% in terms of ACR20. And what we did that during the treatment, we collect those patients, the Chinese medicine symptoms. That means the feelings. Okay, we tried to classify the feelings of those 100 eye patient feelings. And then we tried to connect those efficacy with that feelings. Okay, and then we find out 5 symptoms, okay? The positive indicators, that means once the patient shows these 3 symptoms, most likely the patient will be treated or will be effectively treated by that intervention. That means MTX and SSZ. So also we find out 2 negative indicators. That means once the patient have those 2 indicators or symptoms, they will most likely will not be treated by that intervention. So that means that, so once we can treat the patient, use same intervention, MTX and SSZ, if we can classify the patient with those symptoms, that means positive indicators, and without negative indicators, presumably should be higher effective rate, right? So that's indication. I always say that we try to classify the indication as clear as possible. So, and then we know that 5 indicators, those 5 indicators actually exactly Chinese medicine symptoms. Nothing related to the eye diagnosis in Western medicine. Because Western medicine doctors, they don't care about this kind of feelings. And then we can use randomized clinical trial to approve that. So the second round clinical trial is that we recruit the eye patient, some of them with those indicators, the 5 indicators. Some of them are not with those indicators. So we use randomized clinical trial, and then we can use we call it coding criteria to prove that efficacy. So we can see here, indicator group, the effective rate up to almost 90%, 87%. So that means the MTX plus SZ, the general effective rate is about 60% to 65%. And once you use this treatment in the eye patient with these 5 indicators, that in Chinese medicine, so effective rate will improve up to almost 90%. I think that's a bridge. That's what we need to classify the patient based on the Chinese medicine pattern classification, and also we can combine those classification and Western medicine intervention at the same time. Of course, we can do that actually, follow that herbal formulas, same thing. So what do we need? We need to find out the evidence to prove that, to show that. So I would say that Chinese medicine pattern classification is much useful for the intervention or for clarify the indication for the Western intervention or including Chinese medicine intervention. Another idea actually from Chinese medicine is that, in terms of disease diagnosis and the pattern classification, both in Western medicine and Chinese medicine, that there may be the pattern similarities, the Chinese medicine pattern similarities in different diseases. What we can show that in different arthritis, okay? The arthritis, actually, in different arthritis, in terms of Western medicine, they're completely different, okay? But in Chinese medicine, the arthritis, basically they are in the same or similar category, actually. So we can treat arthritis with more similar principles, like actually in Chinese medicine. But in the Western medicine, they are completely different. Let's say osteoarthritis and rheumatoid arthritis, they're completely different. But in Chinese medicine, they're similar. So we can find out some similarities actually between the different arthritis. So that means in the treatment for the arthritis, somehow we can use similar drug or similar natural compound. We don't know yet, but hopefully in the future we can find some of this kind of natural compound for different arthritis. It's not only for one arthritis. And another one, what we did is that arthritis, rheumatoid arthritis, and coronary heart disease, they are completely different, right? Because rheumatoid arthritis and the coronary heart disease, no relation actually, exactly. Well, let's say if we return off bioinformatics, we can find some of them. Yeah, we are doing that. So, and we found out that actually inflammation somehow, or apoptosis, and also agenesis, are more similar, both in the rheumatoid arthritis and coronary heart disease. So that means maybe we can treat those two different diseases with the same or similar drug or compound. The question is that we are not cure that patient. Maybe we need a combination with another one focused on that different disease. So I think the future medicine is a combination or classification can be used another way. So I think if you combine complete different disease, let's say rheumatoid arthritis, coronary heart disease, and diabetes type 2, there are three complete different diseases. We use a gene sequence technique. We find out differential gene expressions somehow compared to health control. And we can put up this kind of clusters of differentiate gene expressions. And then we can find different clusters. And in the cycle, actually, that's rheumatoid arthritis. That means once you show these 5 clusters, that means can be diagnosed as rheumatoid arthritis. And these 4 can be rheumatoid arthritis in the code pattern in Chinese medicine. And this 4 is a hot pattern. Remember that, but anyway, there will be one cluster that can be different between RA general and RA hot, RA cold. So that means even in the RA patient, you can further classify the patient into different subgroups. And more interestingly is that these 4 can be coronary heart disease. Remember that one of them exists in rheumatoid arthritis, right? And this will be type 2 diabetes. And also one of them in the rheumatoid arthritis. So somehow there will be 1 or 2 clusters. Actually, they exist in those 2 or 3 of different diseases. So how can you classify or diagnose one disease as our therapeutic target? It's real difficult. So in the future, maybe the drug can be classified like that. So maybe drug A can be for the class 1 or class A, even drug A for the class A or B, whatever. So any clusters will be find a suitable drug or compound. And then once a patient got A, B, C, D, and then you can prescribe those drug A and B and C and D. So that combination, that will be, I should say that it's more toward personalized medicine because the classification is individual and that the treatment actually based on that individual patterns will be selected. So I think that's a future medicine. Future means that you try to classify the patient more precisely and then select the treatment. So that, and another idea has come to my mind that shall we classify the patient in disease or in Chinese medicine? Maybe we need network classification. So what to see in my mind that, let's say a community, like a cell, human cells, okay? The community can be, let's say, the cell, let's say 20 proteins is more important. That should be imbalanced, okay, in the normal situation. Like community, let's say 20 family. They are in normal. That means normal community is a normal cell, okay? once a killer comes to the community, whether the killer is from outside or they're produced inside, anyway, the community become abnormal, right? So actually the cell community, it depends on how the situation, even one person is different, but the community will become completely different. So it's not only affect one family, affect the whole community. That's one cell, looks like a cell. So what we should do that, I think it's hard to use a single target. Of course, if you can find the killer, easy, okay? It's not easy, but usually you cannot find the killer. I think that's normal. And then I should say that, and then we need the network classification and the network intervention. The network intervention can be, training those families, how many you trained, this type of things, we need to think about that. So in the future, I think, the network classification and network, the intervention is more important, actually, because we need to do something is most important or most beneficial to the patient. It's not only for the disease or for the Chinese pattern. So what we are doing right now, that's ongoing project, I just show some idea. We don't get any data yet, hope next month, okay? So that network classification, that means I can classify the patient based on that genotype, right? So we can set up individual network for that patient, okay? So that's easy. So now not so expensive, right? $100, I think, I know that for the gene sequence. And then we compute up that network based on those gene sequence data. So we know that's the patient network here. And then we can use herbal medicine. Let's say we have built up about 500 herbs system pharmacology already. That means each herb, the compound, we know that already. So we know those compound target the protein, and then we can combine everything, any data together to build up individual herb pharmacological network. We did already. So what we are doing now is that based on the individual gene sequence data network, and then we can use our herbal pharmacological network to prescribe herbal formula directly. So that's what we are doing that. We call that network-based herbal formula prescription, that system. So we are doing that. So we hope that we can, based on that gene sequence data, and then we can prescribe the herbal formula for that patient, at least for the doctor reference. Another very important, actually real hard job is that how to define the feelings in Chinese medicine. You know that in Western medicine, it's about 300 to 400 symptoms described in Western medicine. But in Chinese medicine, we collect that at least more than 2,300 symptoms. So since all of classification or pattern classification based on in the Chinese medicine, we are based on those symptoms. So we need to do something for those symptoms. So what we are doing that, we try to that network-based symptom gene predict approach. That means we try to link the network between the Chinese medicine symptoms and the genotype. So hopefully we can find out those, we can, based on the Chinese medicine symptoms, and then we can predict those network in genotype, and then prescribe herbal medicine. I think that's the future, and we are doing that. Hopefully next year we can have, version 1 for that platform. Yeah, that's we are doing that. That's kind of, don't ask me that detail. It's one of my postdocs are working on that, or not one of them, 2 or 3 even. So any comment, suggestion, welcome. But don't ask me the more detailed technique about this, technique about that, whatever. analysis. So that's we are doing that. So we have now we are based on the clinical trial, clinical practice guidelines in Chinese medicine. We collect more than 500 different disease clinical practice guidelines in Chinese medicine. We know all of that. The symptoms already, we know how much that, 10,000 something disease symptom interactions. We clarify those already, and now we are doing that. We'll set up, methodology, and hopefully we can do some analysis later. So summary and the future development. I always say that for the patient, we need precise classification. That means what we can do that, we can do for the disease diagnosis and integrate with the Chinese medicine pattern classification, or vice versa. That means you can classify the patient in the Chinese medicine pattern and plus disease diagnosis, because you clarify the patient more precisely. Once you can classify the patient more precisely, and then you can select more precisely your treatment. I think that in the future, I hope that the classification somehow can be integrated together, and hopefully network classification will be, future classification. And then the network intervention, including combination therapy, and even more 3 or 4 or 5 drugs together. Of course, you need scientific background. You need scientific proof that. I think future medical science is classification and intervention accordingly. Not like nowadays, we try to improve more, precisely, and help get more beneficial to the patient. Thank you so much.